All right, we're going to go ahead and get started. First of all, welcome to everyone joining us. It's been really exciting to see more and more of you join us over the last couple months, so thank you for that. My name is Megan Ramos, and I'm the program coordinator with the Riverside Medical Clinic Charitable Foundation, and I get to facilitate these meetings. And so just a couple of things. If for some reason you have to leave the webinar early, or if you want to share this video with someone after, it will be on our YouTube page, which is just under our name, or on our Endometriosis Family Support Group Facebook page. So you can find them both places, and feel free to share and everything like that. So I'm really looking forward to tonight. We have Dr. Julie Sarton with us, who is among the nation's foremost experts on the pelvic floor. And so I'm going to go ahead and pass it over to her so we can get started.
Thank you so much. Good evening. Let me see if I can connect first so I can get my slides up. Okay, thank you. Good evening, everybody. My name's Julie. As Megan said, I have been a pelvic floor physical therapist for the last 20 years, and it's really an honor to be able to share this next hour with you and talk to you about something that truly is something that I feel like I was created to do. I'm going to share just a little bit of my background. I got into this field of physical therapy, which is a niche practice, again, 20 years ago. When I was in grad school about 25 years ago, I had a late uncle who was a very prominent OB-GYN doctor who specialized with pelvic pain, particularly with endometriosis, and he ended up co-founding the International Pelvic Pain Society. And when I was in grad school, he was always planting the seed about how he was treating all these women with endo and other pelvic pain disorders, and how he would take them to surgery and remove the pathology, yet they would come out of surgery with remaining pain. And so he really started, shaking his head saying, what else is going on here? Because obviously we are missing something. So he just started reading everything he could get his hands on, and he discovered a book, we'll talk about it later, and it's by two physicians called Dr. Travell and Dr. Simons, and they wrote a book outlining all of the trigger points within the muscular system of the entire body, and there was a chapter on the pelvic floor in there. And my uncle decided, he's like, this is what I think is going on with my patients. There's a muscular component to their pain that no one's addressing. So he actually flew out a PT that's the generation before my generation, and he brought in 13 patients and brought in the PT I ended up mentoring under, and they went through on a Saturday, and they went through case by case, and they were able to help all of these women who were suffering with pain. So I was very fortunate that he was able to, again, plant the seed, and then as soon as I graduated, I was able to mentor under him, and I soon learned that his passion became my passion. Fast forward about 10 years after that, after I was married and I wanted to start a family, I battled a long journey of infertility. All along, I already had battled my own pelvic pain. So I had severe dysmenorrhea, which is very common with endometriosis. That's severe pain with your menstrual period, every month. And I had GI issues and bloating and IBS. And so, through my journey, I was able to also come up with treatment regimes and protocols that actually helped me. And I'm going to share many of those with you tonight. Okay, so let's dive in. So really we're going to look at very specific evidence-based approaches to endo. We're going to look at what the pelvic floor is, first of all, and then how and why they become involved with endometriosis. We're going to look at how pelvic floor treatment, specifically with physical therapy, can improve symptoms of pelvic pain that comes with endometriosis. We're going to look at the inflammatory role of endometriosis, and then what to expect if you pursue pelvic floor physical therapy. So just to make sure we're all on the same page, let's just go back and redefine what endometriosis is. It's an abnormal growth of the uterine lining that manifests outside of the uterine cavity. This can show up anywhere. They have even found in studies reported that endo can show up on the brain level. The only way truly to get a definitive diagnosis is through surgery. Through exploratory laparoscopic surgery. And so it's important to know that there's not, a CT scan, an MRI that's going to reveal it. I will tell you that there are some advanced physicians out there, and if endometriosis is very advanced, you can detect changes with a manual pelvic exam on some specific structures. So some of the key things that we see with endo implants is that typically the cervix will not sit central. It will actually be pulled off to the side due to something called the uterosacral ligaments. And endo commonly will implant on those ligaments, and so they become very dense. And again, a good physician can palpate and just sense, we don't confirm, but, I suspect that you may have endo. And typically when this happens, it's a very painful exam. So I have had this exam done on me, and this was actually not so long ago. And my uterosacral ligaments exhibit evidence of endometriosis. And I flew off the table when the physician actually was able to palpate these structures. But your standard OB-GYN probably is not going to have training to do this. So at the end, if you have questions too, then you can always email in. We're connected with some pretty good physicians if you already are not yoked with somebody that you feel is appropriate for you. Okay, so another point I wanted to bring up is endometriosis. It is more common than people think. It's as common as diabetes and asthma, but yet it really does not attract the same attention, support, and the effort to fight the disease process. So this last year, the American College of Obstetrics and Gynecology, the president, because there was a lot of pressure out there through social media and patients, saying, ACOG, it's time for you to really listen up. We need physicians that are armed and equipped to be able to help patients. And so if you were on social media, you might have seen there was a significant march that was done in Washington, D.C. And so the president of ACOG actually said, yeah, you're right. It's time we have to talk about endometriosis. And some of the things that were pointed out in this article are, I think, just unbelievable. So on average, it takes about 10, in fact, some statistics will say 11 years from when a woman first experiences her first symptoms to receive an endometriosis diagnosis. Over half of general practitioners out there, they don't feel comfortable diagnosing and treating patients with endo. And then even half are unfamiliar with what the main symptoms of the disease are. So we're going to review that tonight. So you guys are really confident if you suspect that you have this or if you've been told that you have endo. And obviously, the earlier that we can diagnose, the earlier we can treat, and then we're going to have better outcomes overall and increased quality of life. So what are the typical symptoms? So painful periods, the hallmark classic symptoms everyone knows: painful periods, ovulatory pain, pain with sex or intercourse, and infertility. But other symptoms that necessarily people don't recognize, constipation and diarrhea, so bowel issues, bloating, back pain and groin pain, pain with defecation, and then it's very common to have urinary symptoms as well with endo, particularly urinary urgency frequency. Some patients are actually diagnosed also with something called interstitial cystitis. So because the symptoms tend to be all over the place and there's a huge variability, it takes typically a long time for physicians, to come up with this diagnosis. And so, we just talked about 10 years. There was another study that quoted 11 years. So now in general, when we look at pelvic pain, we know that almost half of all laparoscopic surgeries are done for pelvic pain, but if you find endometriosis, only about a third are going to have a resolution of their pain with surgical intervention. So this goes back to the story I was sharing with you about my late uncle, what he found. So he's like, that's not the sole solution. Something else is, there are other pain generators. Something else is playing a significant role here. So when you look at adhesions too, which are very common in scar tissue with endometriosis, if you do something called adhesiolysis, which is surgery, it's only beneficial in about 40% of patients. So we're going to just talk quickly about surgery. I'm not a surgeon by any means, but I just wanted to throw in so you're up to date with what the literature says. If this is a treatment option for you, when you look at surgery, there is something called excision versus ablation that can be done for surgery. And ablation is essentially what happens when you burn endometriosis versus going in and excising endometriosis. And with ablation, the disadvantage is you can get a greater area of necrotic tissue, and that just means dead tissue is left behind, and you get increased inflammatory action, and so therefore you're at higher risk for adhesions. So something to think about then for, if you are contemplating surgery, again, just keep this in mind, and we can talk about that later. We already hit upon this. Why does pain last after surgery if you've had surgery? So looking at the inflammation that gets triggered, okay, sets the stage for scar tissue, which can adhere through your abdominal cavity and pelvic bowl. And so one of the many take-home messages tonight is we want it to be standard of care after surgery that you go to pelvic floor PT, regardless of what kind of surgery, whether it's endometriosis or any other pelvic surgery, because the manual therapy that we're going to talk about tonight will reduce scar tissue and the muscle spasm that so commonly is present when you suffer with this. And these absolutely can be reversed with physical therapy. And I threw a study in here just to reference too, a recent study in 2011, and they looked at the effects of PT, and they found if you had a total of 20 hours of what's called manual therapy, it decreased pain symptoms by 90%. So that's very encouraging. This is an article that's written out there, and it's called Pelvic Pain Without Pelvic Organs, and it was written back in the 90s by two physicians, and they outlined 4 cases of women who had severe pelvic pain due to different diagnoses. And so this is one I just highlight, and I love to share this also just with physicians again and patients to get you thinking about other options, conservative options of treatment besides just surgery. So quickly just highlighting, there was a 29-year-old female. She had pain since she was 22. She ended up at age 23 having her uterus removed, and then they removed pelvic adhesions and scar tissue. She was undergoing medical management with pain medication and pain management. A repeat surgery then happened at age 26. She was diagnosed with interstitial cystitis. Everything was failing. So they went ahead and removed her bladder and her urethra. And unfortunately, after that, she still ended up with pain. And so the take-home message of this is that, first of all, before you ever have any kind of organ ever removed, and the two authors concluded this, you have to always look at the pelvic muscular element. And that's what I think we're missing a lot with our treatments is the pelvic floor. So the pelvic floor is a group of skeletal muscles that form almost like a hammock structure, and that these muscles are like every other muscle in your body. They just happen to reside on the inside. So they actually attach from your pubic bone in the front. They wrap around the vaginal opening. They wrap around the rectal opening, and they go back and attach to the base of the spine here. And we have multiple muscles collectively that we consider the pelvic floor. So we look at why does it even become involved, and really why do we care, right? So these muscles are very different because they have such an intimate relationship with the organs, particularly the pelvic organs. And these muscles, they are called upon in all aspects of life. So, for example, when we sit on them. When we stand, they have to contract immediately to help hold up all our organs. When we walk, they fire with other inner core muscles to create stability. That's one of their roles. They have to lengthen out appropriately to have intercourse. They have to be able to contract and be strong to help build with orgasm. They have to be strong also for their sphincteric role, so they can help keep us continent. And then obviously, like we talked about, they support and hold up the organs. So they're super important, and unfortunately no one talks about them until a problem starts to happen with them. They also work to help stabilize something called the sacroiliac joint, which is the lower lumbosacral in the lumbosacral region. And they keep our pubic symphysis in the front. They can keep compression there. They keep it stable. And these muscles, they really are considered part of what's called the inner core. They have a very important relationship with the diaphragm. So when we take appropriate deep breaths, and the diaphragm drops, the pelvic floor drops. But if our breathing patterns are faulty, this actually can be something that's an underlying perpetuating factor why our pelvic floor becomes unhealthy. And what makes these muscles also unique is that they're under the control of the autonomic nervous system. So our autonomic nervous system is divided into our fight or flight, our sympathetic nervous system overdrive, and our parasympathetic nervous system overdrive. And so what happens when we undergo a lot of stress, we're bombarded with whether it's physical stress, emotional stress, any kind of stress, or trauma, the sympathetic nervous system starts to go into overdrive, and that will light up the pelvic floor. They did some really fascinating studies actually several years ago of women who had pelvic pain and pelvic floor muscle spasm, and they used needle EMG, and they measured the electrical output of what the muscles were doing with women just lying on the table, and all they did was watch scary scenes of a movie, but nothing physically changed. They didn't have them do any kind of activity, but when they had to watch that scary scene of a movie, or they had to do some difficult arithmetic, the electrical output of those muscles shot way up without, again, anything changing, which is just fascinating. So it also tells us the importance of the mind-body, which we'll talk about in treatment, and making sure that our nervous system stays in check. So when we look at all these muscles, and we're looking at patients that suffer with endometriosis, those patients are considered to have, typically almost all patients will have what's called then pelvic floor muscle spasm or pelvic floor tension myalgia. So it's myofascial pain. Myo means muscle. Fascia is connective tissue. And this is really an extremely common thing that we see externally as well with all the muscles, but just internally within the pelvis, unfortunately, it's just not identified as much as it should be. So what are some of the symptoms of when the pelvic floor muscles go awry or they have this pelvic floor tension myalgia? So you can get achy pelvic discomfort and pressure, different than pressure from a pelvic organ prolapse, pain during or after intercourse, any kind of vaginal pain, common descriptors of sharp pain, burning pain, throbbing pain, radiating, any kind of abdominal pain, low back pain, hip pain, urinary symptoms, hesitancy, retention, painful urination, rectal pain, functional bowel disease, or pain with defecation, pain with sitting in your tailbone, or what we call the sitting bones, the ischial tuberosities, pain with your annual exam when you go to the OB-GYN, or pain when you try and insert a tampon. These are classic symptoms that make you go, if I'm suffering with any of these, there's a good chance I've got a pelvic floor muscular component, whether I have endometriosis or not. Now, look at the symptoms of endo, okay? Painful periods, pain in the lower abdomen and pelvis, low back pain, pain with sex, nausea, vomiting, pain with urination or bowel movement, infertility. So take out the infertility, all the rest of those. There is a huge overlap, right, from just the muscle dysfunction and then the typical symptoms of endo. So take-home message is, if you have this, you have to have somebody look at what your pelvic floor muscles are doing, because there's a very good chance that they are a pain generator, a part of the pain presentation. And the good news is they can be helped and they can be changed. Okay, so let's go into what a pelvic floor exam looks like, and then a little bit more with the diagnosis. If you were to walk in for pelvic floor PT, the first thing, just like if you were to walk in with an MD, is we have to really go through a good history, and this is so critical and it's so important, because we really have to look and see if there's any specific stressor or trauma that preceded or is currently exacerbating your pain. So from a physical therapy standpoint, we're always going to look at, even if you say, hey, I've been diagnosed with endometriosis and I have already, and that was occurred through laparoscopic surgery and confirmed, the pathology was confirmed, we still are going to look at other things that would influence your presentation. So these are just some of the examples that we would ask. Okay, well, tell us what else has happened. Have you had any falls in the past? Because if you have, that could influence the position of your tailbone. We're going to look at the hips. We're going to look at the pelvis. Any other lower extremity injuries? What other surgeries have you had done? And then childbirth. Have you had children? If you have, what kind of delivery did you have? Was it vaginal or was it C-section? That's going to make a difference. And any complications that occurred. Any prior auto accidents or whiplash injuries that could have influenced the spine. We're going to look at, what do you do for a job? Are you sitting all day? Are you sitting, compressing your pelvic floor all day? Are you a dental hygienist where you're sitting on a little stool and you're rotated and maybe sitting asymmetrically and just loading up one side of your pelvic floor? What is the demand of what you do? Any history of abuse, any chronic holding patterns, which can be breath holding, can be abnormal urinary or bowel holding patterns. I once had a patient who just had a phobia. She did not want to go to the bathroom in a public place. So she would go to work and she would hold her bladder literally for 8 hours all day. Her pelvic floor was in overdrive. That is not a normal behavior. So when she came to me, her muscles were so short and taut that they were creating pain. So we had to fix the underlying holding pattern, obviously, if we were going to fix manually what was happening with the muscles. So any history of low back pain or SI joint dysfunction. These are all things that we look at. So I'm going to share with you, this is a patient of mine that came in several years ago. She was a young girl, and she had really severe left lower quadrant pain that was significant every month with her period, but it took her to the ER routinely a couple times a month. And so finally the doctors said, well, let's go ahead and take you in and let's do exploratory laparoscopic surgery. So they did, and they found mild endometriosis. So they removed it. And unfortunately, about 3 or 4 days after surgery, her pain returned. And so the physician said, then it's got to be in your head because we removed all the pathology. So she happened to read an article that I wrote that was just floating out around there, and she was reading about the pelvic floor muscles, and she's like, you know what? I think maybe this is what's happening. So she came in to see us, and when we do the pelvic floor evaluation, one of the things after the history we first look at is, how do you stand? So this is a postural analysis, and this is her. So I got her up and I stood her up. I'm like, okay, let me look. And you guys I don't expect you to be physical therapists or anything, but I just want you to see in the first picture, if you can notice, she has a significant sway back right through there. And this, to me, is a red flag. There's something actually called the pelvic pain posture. And it's an increased sway back like she has with an increased kyphosis, which means more in the thoracic spine, you get a rounding, and an anterior pelvic tilt. And that first picture manifests all of that. So I was like, okay, I hadn't even done anything, but I'm just looking at her posture because it's telling me a story of her body. And then if you look in the second and third picture, the glaringly obvious thing is how she stands. If you can see her feet, they're externally rotated. She's standing kind of like a duck. And if you can guess what she did for years and years, just standing like that, I was already like, uh-oh, she's in trouble. She was a dancer. She was a ballet dancer. And so she was stuck almost in, that's a plie position, and that's an externally rotated position, which for you, hopefully I'm not losing you, that just means that that's going to shorten down a couple of her key muscles inside her pelvis. So before I did an exam any further, I already knew that, she was in trouble based on just how she was standing. So let me go back because I'll finish her story real quick. So when we got her on the table, and I'll go through, you're going to see in the exam what we do on the externally to assess what's happening with the fascia and the connective tissue on the outside, and then we check with an internal exam. I was able, once we did that, I was able to palpate some key muscles that actually reproduced all her left lower quadrant pain that took her to the ER. It was her exact pain. And the good news is it was rooted in her muscular system. And yes, she had endo, and yes, it was removed, but the remaining pain was still there from the muscular component. So we were able to treat her within 3 months or so and get her pain reduced and increase her quality of life. Okay, so this is just a study talking about the pelvic pain posture that exists. We're going to skip over it, but just so you know, it's actually been validated in the literature. So this is another typical example of what would happen in a PT evaluation. We look and see, how do you move? What's happening with the spine? What's happening with the sacroiliac joint motion on each side? And why do we care about that? Well, if we find that there's hypermobility here, we know that all the pelvic floor muscles on the inside, they attach to the base of the spine, and they tend to compensate, and then we'll try to create stability there. And a strategy a lot of patients that we find use is that the muscles will just hunker down into spasm. It's not a great strategy, but it's a strategy to try and create the stability through the lower back. So we always have to assess and see what's happening with that. We look at, how are the hips moving? If they're restricted, that's also a clue. 2 of the pelvic floor muscles on the inside we're going to look at leave the pelvis. They attach on your hip. So if we have a restriction with how well those hips move, we go, uh-oh, again, higher risk for the pelvic floor muscles inside to be dysfunctional and short and tight. Then we look at what the bony structure, here's the pelvis itself. If we have an issue with how the pelvis sits, so if one side sits higher than the other, if there's a rotation, then all those muscles that are missing here, but if they were here, remember they attach from front to back, then they are not going to attach symmetrically side to side. One side will be short and compressed, and the other side will have to compensate and be long. So this is an example of me just assessing this with a patient and then doing a technique to correct it because I found some asymmetry with how her pelvis was sitting. Then we want to start in with palpation, and we're going to palpate through different layers. We're going to look at what's happening with the skin, the fascia. We're going to look at what's happening with the muscles and the ligamentous system. So again, you're not PT, so you guys don't need to know this, but just so you can see a picture, because it gets there's a lot of stuff going on in here, and this is just the ligamentous component of what's happening. The top picture now is me actually coming in, and we look at the muscle layer, both the fascia and the muscle. And so my fingers, my hands on the top are showing a very key external muscle that happens to fascially attach to the inner muscles, the pelvic floor muscles. And this is called the psoas muscle. And it's a common muscle that it becomes restricted and tight and manifests what we call trigger points that create pain and can actually send pain elsewhere. They have these characteristic referral patterns. So part of what our job is as a pelvic floor PT, again, on the outside of the pelvis, is to try and map out any other structures that are generating pain. So that book, Travell and Simons, I was telling you about at the very beginning that my uncle referenced, this is pulled from it. And it's just a picture of the X's show you where the most common trigger points are for these particular muscles. And then the little purpley dots, or the light dots coming down, that shows you the referral pattern so sometimes the pain is experienced or perceived in a different area. It's not always necessarily where the pain is generated from. Okay, so the next thing we look at then from a physical therapy standpoint is, what is your connective tissue doing? And not everyone understands what connective tissue is, or what we call fascia. So I always like to explain, I keep it simple, that fascia is three-dimensional spiderweb-like material that sits under the skin. We actually have multiple layers of fascia. So the first one is right under the skin. The deeper layers actually, so you have a layer over the muscle, you have a layer over every organ, nerve, and vessel in your body. And anytime you cut with surgery, or even if you have just a postural dysfunction, the fascia can change and the fascia can become restricted. And you can imagine, like, if you have your shirt, right, and you just take your hands and create some tension and pull down on the bottom of your shirt, see how you create a line of tension and pulling on the top of your shirt. The fascia that's what happens when we get a restriction. The fascia is continuous. And it goes actually throughout the entire body. And this can be a huge source of pain that is missed again and again. So you can see in this lower quadrant on the lower left-hand side, I'm doing a technique called skin rolling. And I'm using the skin as an anchor to lift the fascia. And when the fascia is healthy, it feels smooth, the skin feels smooth, the fascia underneath it feels smooth. But when it's unhealthy, it feels the ground substance has changed and it feels gunky and it feels lumpy and it actually is quite painful to do this. So it's both an assessment that we do as well as a treatment we do if we find that the tissue is dysfunctional. Let me go back to this. When this is dysfunctional, what happens is it sets up, unfortunately, a reflex called the somatovisceral reflex. And soma means skin and viscera means organ. So let's go to the uterus, let's go to the bladder or the vagina. It doesn't matter where. But this restriction in the fascia will promote inflammation on an organ level. And it shows up, actually, the fascial restriction, typically due to like the inflammation from the organ level. So endometriosis, it's very common to have the abdominal wall with significant fascial changes, the inner thigh muscle area, fascial changes, the gluteal, perirectal area with fascial changes. And the good news is, since the the reflex is reversible, you can drop the inflammation on the inside by normalizing this fascia. It is the coolest thing ever, and it's something we teach all our patients to do. And then we also look to see what happens with the main nerve that innervates the pelvis, and this is called the pudendal nerve. And so you're just seeing different positions that I'm doing this in, and using different techniques to actually palpate the fascia and the muscles around the nerve and the irritability of the nerve itself. Okay, so this is a close-up of the pelvic floor. So just to orient you, okay, so our sitting bones would be over on each side. The perineal body is right in the middle, and the little red arrows coming down, these are muscles, and these are very superficial muscles of your pelvic floor that are on the outside. So you can palpate these without even going internally in the vaginal canal, and these also can create pain and dysfunction. Now, this is a picture of deeper inner pelvic floor palpation. So this is what we do with our pelvic floor exam. In a perfect world, this is what every OB-GYN should be doing every time you go see them for an annual exam. They should be doing a pelvic muscular exam. Unfortunately, many are not trained to do this in med school, so it's not happening, but you absolutely should request it, and if they don't know, then you need to get them hooked up with a good pelvic PT who can help educate and train them how to do this. So you have, again, multiple muscles coming in that we palpate systematically, and we map out to see which ones manifest these trigger points or taut bands, and we look at the health overall of the pelvic floor muscles. And then we're interacting with you as a patient, so that you're telling us, okay, yes, that hurts, and that actually creates, quote, ovary pain. And I mean, it's different for everybody, right? So I've had in the past, when I've done this, one time I had a patient say, please stop flicking my ovary, that hurts. And I had to assure her, I'm like, that's not your ovary. Your brain thinks it's your ovary, but it's your pelvic floor. It just can't interpret where that stimulus is coming from. And so, so some of this, again, can reproduce even menstrual cramping pain. I mean, there's so many common descriptors that we'll get. Sometimes it's sharp, sometimes it's achy, sometimes it goes, to the rectal region, sometimes it reproduces low back pain. Just depends. It's variable for each patient. That's why everybody has to be mapped out specifically. So this just shows, again, another picture of the pelvic floor, and there's one of the main muscle groups is called the levator ani muscle group. And very commonly, it doesn't mean if you have trigger points in your levator ani, you're going to have all of this, but these are the most common descriptors when we find, if I go into a pelvic exam with the pelvic floor and I find that the levator ani muscle group has trigger points, so very common referral up to the abdomen. A lot of people, again, they're like, oh, I thought that was my GI pain, or I thought that was only just because I really have endo, or I thought it was really because I have something else, IC, but it really is rooted in the muscle. So common for abdominal pain, bladder pain, urethral pain. Some patients swear they have to pee if these muscles are dysfunctional and you palpate these muscles. And some patients will get this feeling of a golf ball in the rectum discomfort is a really common symptom that we actually hear. Another muscle, this is a back view. So here's the hip right here, and then this is the base of the spine. So this muscle is called your coccygeus muscle, and it goes right onto your tailbone. And so this is just another example. Again, I don't expect you to know names or anything else like that, just showing you that, wow, if you have restriction of this muscle, that can create pain in your tailbone or your big glute muscle, or definitely pain with defecation or afterwards, or any kind of rectal or anal pain too. Okay, so now I'm just going to walk you through what we do as PTs for treatment if you were to come see us. Okay, so our role is a big educational piece. I mean, that's where we start, and knowledge is power. And so our goal really is to teach every patient to become their own PT so that you can help manage your symptoms lifelong. The mainstay of what we do is using our hands. It's called manual therapy, and there's advanced techniques that, again, that I've kind of shown you, we'll go through too, to help treat both externally and internally. And that can consist of skin rolling and something called myofascial release. We can use modalities. We have a class 4 laser in our clinic that brings in an immediate, beautiful pain relief. It penetrates about 4 times the depth of a traditional ultrasound, and it brings in blood flow, and it creates on a cellular level more mitochondria. They're the powerhouse of the cell. We then will look at, once we lengthen and normalize tissue, we have to strengthen patients up, because a lot of patients with chronic pain, they don't have normal strategies with their movements and walking patterns. So we have to re-educate so that we can put back the right appropriate strategy. And then obviously a home program. So this is, again, just a smattering example of some manual techniques that we would be doing, always, again, starting on the outside before you move to the inside. Regardless of where you go, you just want to make sure if you undergo pelvic floor physical therapy, there needs to be both external and internal work for it to be ideal and to get the best outcomes. We have over 35 muscles that attach on the pelvis alone. So you can't just look on the outside and you can't just look on the inside. You have to look at both. I'm going to talk a little bit more about muscle, just so you understand too, because when patients come in, they're always like, how did you know? How did you know which muscles to touch? How did you know you're going to find that there? And I always say, I'm like, because everybody else walking in manifests these patterns. I mean, it's not always exactly the same, but we see patterns. And why do we see these patterns that exist? Because there was Dr. Yanda way back when, and he really outlined this. And so what he explains is, when you have an inflammatory process that's going on, okay, you get certain changes within the muscular system. And so the changes in muscle tone and their ability to contract, they do follow a certain pattern. And so we know that certain muscles will actually get inhibited and turned off, and they're not going to work when we have those pain processes going on. And these are the muscles. And again, you don't need to know these names, but your PT does. And then there's certain muscles that get over-facilitated when this process happens. And down low, there we go, there's the pelvic floor. So your PT needs to know this too, because these are the key ones that we have to quiet down, while these other muscle groups are the muscles that we have to wake up. And that's part of what you do in physical therapy. All right. So another just take-home message is to realize that you are a system of connections, and you are connected head to toe. And so again, we don't just want to treat inside the box. We have to look outside the pelvis. We have to see the influence of what's happening above and below. So this is just an example. Your hamstring. So the hamstring is the muscle in the back of the thigh. It actually crosses over the pelvis, and crosses over the hip and attaches onto the pelvis. And it crosses over the knee, the back behind the knee, and attaches onto the tibia, which is the lower leg. So literally, this is a bridge that connects. Now, as it comes up onto the pelvis, it actually attaches right up through here to your sitting bone. And your pelvic floor also attaches to your sitting bone. So if you have a very, very tight hamstring, this is going to yank on your pelvic floor internally, which already might be irritated from, again, all the inflammation, scar tissue adhesions that may be there due to the endometriosis. But again, to treat holistically, we have to look with a wider lens and go, okay, well, what else? What else then is making these muscles angry and irritated? And then we have to treat down the leg. Okay, we already went through just what internal treatment is. Sometimes what we do, what a patient will require is something called an SI joint belt, because one of the things when we look back at, okay, we got to see what are the movement strategies like? And some people have a very weak core. And so for a while, we have to create some stability through the inner core, and we can use something called an SI joint belt to do that until the muscles can take over. And that's the strengthening component of what we do. And this is just an example. It's progressive. You can't start with advanced exercises. We have to assess where you are just with your strength and what your strategies are, and then we start to build in a very key specific program for you, an individualized program just for you, for each patient. Okay, I threw this study in just to back up and show you evidence that actually manual therapy, pelvic manual therapy does work with chronic pelvic pain. And this was a study that was done back in 2009, and there were almost 50 patients. There were 48 patients. And they basically put them into two groups, and one actually received internal and external PT, all the stuff we've been talking about, and the other just went and got global therapeutic massage. And the difference was that the PT group actually had almost 60% reduction in pain versus 20% with the global massage. So the massage still did something, and the massage, again, a good massage therapist is great, but it's much more effective to make sure if you can get the pelvic floor specific techniques used that we just discussed. All right, so this is an example of a home program technique that we'll put a lot of patients on if we find that the pelvic floor muscles are too hypertonic, they have too much spasm. If there's pain with intercourse, these little clinical tubes are called dilators. And we teach patients how to use these so that the patient at home can work to release trigger points within the pelvic floor and lengthen the pelvic floor out. It's a very common thing that a lot of our patients will get as part of their home exercise prescription. And dilators, if pain with intercourse is present, dilators come in different sizes, and the goal is you always start with a very small dilator that is relatively, pain-free, and you work up slowly to a larger size dilator through a progression of stretching, and we teach you how to do this, never forcing it, but as you work to stretch and lengthen the muscles, that sets the stage for you to advance to the next dilator. Another tool a lot of our patients will use at home is called the crystal wand, and it's this S-shaped tool that allows you, unlike the dilator that's straight, it allows you to actually hook in and around the muscles. The muscles don't just run straight front to back. Remember, a couple of them leave the pelvis and attach over on your hip. So this allows you to get in as a patient and treat different angles to release the muscles. This tool actually is originally designed as, believe it or not, a sex toy for the G-spot, but we in the pelvic floor world, we use it for trigger point releasing. And we tell our patients you can do whatever else you want with it too. Okay, this is one of many, many stretches that we start to educate patients on. This is called the squat stretch. And so this is a beautiful way to release the pelvic floor. If patients cannot get into this position, then there's a variation we can teach them on the back, which is a modification of a yoga position called Happy Baby. All right, so that's just hopefully just a glance. It's a quick overview of pelvic PT and what an evaluation would look like, what treatment, an example of what some treatment would look like. We're almost done. I just wanted to highlight a few things with some medical management as an adjunct to PT. Again, one of the things I help educate patients on is there is never going to be just one specific answer. your treatment is almost always going to be multimodal, meaning that you are going to have multiple different pieces of the puzzle that are going to be addressed. And when they all are addressed, that's when the magic starts to happen. So we have to figure out like all the potential pain generators, right? So we need to make sure that the true pathology of endo is addressed. We need to make sure the muscle component's addressed. We need to make sure the inflammatory process is addressed. We need to make sure if there's a nerve component to it, it's addressed. We need to make sure the mind, because now we understand the pelvic floor is under the autonomic nervous system's regulation. So we have to make sure, that we have a mind-body component addressed. So when all this comes into play, that is when true healing starts to happen, the relief starts to come in. So for medical management, sometimes with the physicians, then we look at other things if PT is not enough, such as trigger point injections or actually shutting down the main nerve that innervates the pelvis called the pudendal nerve with a block. Some of our patients who have really, really severe muscle spasm, and if they walk in through our doors and they've had pain, pelvic pain and muscle spasm for 15 years or 10 years, we look at something called Botox to the pelvic floor, because it's the longer the pain's been there, the harder it is and the longer it takes to undo. So sometimes we cut to the chase and we go, okay, it's going to take a lot more than our hands, and we just layer in. But there's a sequence. We never just run and start with Botox. And then, of course, we have local medications that we suggest. We can't prescribe as physical therapists, but that we suggest to physicians. So many of our patients will use a vaginal or rectal muscle relaxant suppository. And this is a beautiful way to help get the pelvic floor into a relaxed state. And particularly when patients come and they just start with us and their pain levels are high, we typically will recommend this to a physician to be used daily for the first 30 days to help break that pain muscle spasm cycle. And these can be used, there's just various different cocktails and different meds that can be used, but again, instead of taking it orally and having side effects, you can actually put it where you need it, and you can put it in vaginally or rectally. Okay, so if you want more information, our website is pelvichealing.com. We have a blog up. We update it routinely. And you might just want to read about some of the other things too that just pelvic floor therapists treat as well. If you happen to be on social media, we're updating our pelvic healing site on Instagram and Facebook. And if you have any questions too, you can always reach out through our front desk. It's frontdesk@pelvichealing.com. And just to wrap up, before we go to some questions, I really think, again, is collectively we just keep educating and keep the conversation going, because the conversation is not where it needs to be by any means yet. I mean, I've been doing this for 20 years, and finally people are talking about the pelvic floor. But, I mean, with the 11-year time frame that it takes, sorry about typo here, from symptom onset to diagnosis and the treatment of endometriosis, that is totally and completely unacceptable. So we have to stop, we have to create a stop, and we have to change that. And I think hopefully that, if anything too, if you're suffering, just to have the belief that hope and healing are always possible. That might not, there's various degrees of that, but certainly, know that there is help, and it's just not that you're destined to live with chronic pelvic pain. So that is it. I'm going to open it up for questions.
Great, thank you so much. So if you all look on the right side, there's a Q&A box, and there's also a chat box. You can use either of those to message your questions, and then I'll go ahead and ask them out loud. So let's see. Okay, so one question we have is the pelvic floor what is hurting after I have sex? Is it hurting because it is being touched?
So that is a great question, first of all. To truly 100% answer that question, I would need to get you on the exam table. Because potentially, yes, the pelvic floor absolutely is going to be touched during intercourse, because the pelvic floor muscles have to remember, they have to elongate. So even from penetration, those superficial muscles, they have to lengthen out. And then the deeper muscles also have to lengthen out, okay? So if they are short, tight, and have trigger points and muscle spasms, they are going to create pain with intercourse. It's a very common cause of pain with intercourse. And sometimes there's a delay, and some of our patients will tell us, oh, it's not just during intercourse, there's actually pain after intercourse. But other things can also create pain too. So if, for example, if you have endo that has implanted in the posterior cul-de-sac, or that can also be. So really we need a good pelvic exam to help us delineate, and it might be both that are contributing to pain with intercourse.
Great, thank you. So our next question is the Botox treatments or any other injections covered by insurance like it is for migraines?
Another good question, and I wish I could say yes to this question. Unfortunately, for most patients, Botox is not covered for the pelvic floor. It is a fight that many of our patients have to fight against, and they consider it, quote, experimental. Eventually, I think the tide will turn, just like it did with headaches, but it took years for migraines, to get it covered, because it used to be considered experimental as well. We just need more studies, and so encourage, if you are seeing a good physician that's treating endo, please encourage them to contribute to the literature, even if it's case studies about the effectiveness of Botox, so that we can go to the insurance companies and say, no, this is actually, again, the literature supports this. This is a viable treatment option for me.
Great. So our next question is, I'm in Oregon, so I can't come to your center specifically. Is the first step for checking on my pelvic floor going to my normal doctor or a physical therapist?
So good question. So first step ideally would be, I don't know if Oregon is the same as California, but California we have direct access, which means that a patient can come see us without a physician referral. Since we are the musculoskeletal experts, you would ideally want to see a PT to get the muscular exam, because you got to remember, not all physicians, most physicians, I would probably venture to guess, probably 80% of physicians are not trained to do a pelvic muscular exam in medical school. It would be a question I would ask if you call your physician's office and just say, I'm looking for a good pelvic floor muscular exam, is Dr. So-and-so trained with that? Then that could also save you time too, before you just show up in the office and request it there in front of the doctor. So typically a good pelvic floor PT is yoked with a good OB-GYN doctor. So if you find, and vice versa. If you find a good OB-GYN doctor, they should be in alliance with a good pelvic floor PT if this is what they treat. So if you are in a bigger city, what I would suggest is you can go on, it's called pelvicpain.org. It's the International Pelvic Pain Society's website, and you click under Find a Provider, and then you can see all the providers that are in your city or close to you. And most of the clinicians, whether physician or PT, that are part of the International Pelvic Pain Society have experience with the pelvic floor and can do a muscular exam.
Okay. Our next question is this what Kegels help with?
Okay, Kegels, the Kegel question. You have to be very careful. So that is, we're going to bust a myth right here. So, because everyone thinks, oh, pelvic floor PT, you go learn how to do Kegels. So, most of our patients coming in, the pelvic floor muscles are already in a contracted state, which is almost like a permanent Kegel. So we actually say Kegels are contraindicated for you if we find this. If your muscles are short, tight, and in spasm, the last thing we want you to do is tighten them even more. We have to undo that. We have to do what's called a reverse Kegel. We have to lengthen out your muscles. We have to make them, healthy again, and then teach it how to go through its full range of motion. So I always tell patients, you shouldn't just start doing Kegels without learning what state your pelvic floor is in or seeing a pelvic floor PT, so that they can assess and tell you, oh, this is the the length of your pelvic floor is healthy or it's not healthy, and we may need to do some manual therapy first before you ever start contracting your pelvic floor. So it doesn't mean you can't ever do a Kegel, but for some people, if you start doing that, you can make things worse. You'll make your pain worse before, before it gets better. So be careful. Good question.
Great. So our next question is, why do you think some surgeons don't tell you from the beginning that all your pain might not go away?
I think that's a hard question, and I think it's probably individualistic too, but I think because I think a lot of practitioners probably feel that we don't have all the answers yet. And I think we are still learning, and I think that's what makes it challenging too. I think chronic pelvic pain there is hope, but there is absolutely healing, but it's a challenging thing to treat because there's so many potential pain generators that can come in. It can be a result of true pathology of the organ, right? But then it can be a result also of the muscular system. It can be a result of what's happening in the GI system, which we didn't even touch on, because that's a whole different talk. That's like a whole another hour. If you have chronic inflammation in the gut, so many things now are coming back to the health of what's called the gut microbiome. And so diet is huge. Eating the wrong inflammatory foods are huge. I mean, that will promote pain. So to answer that question, I think, again, part of the challenge is you have to make sure, again, the magic happens when you figure out for the patient in front of you or yourself, these are my pain generators, and now I can address each one of them with treatment. And so it takes, I always say it takes your village, right? So it's going to take a healing team. Rarely is it just one person. It's not just going to be the physician. It's not just going to be the PT. It's going to be your doctor and your PT and, potentially a nutritionist that's going to help you that really understands, or a functional medicine person that understands the role of foods, and perhaps like a guided imagery therapist to help calm the mind, to help with the anxiety and the stress, because we know that'll turn down what happens with the pelvic floor. So hopefully that answers. If you have another question related to that, let me know.
Okay, great. So it looks like that was our last question, so I'm going to end on this comment that was shared. One of our listeners says, "Thank you for sharing. This was incredibly informative, and I love getting glimmers of hope like this and seeing women doing good work helping other women." Aww. And so I just want to echo that and thank you for joining us tonight and sharing with us. It was incredibly informative, and so thank you so much.
Absolutely, absolutely. And if anyone has any other questions, feel free to email the clinic too, and we'd be happy to answer them.
Okay, great. And just a reminder, everyone, this can be posted on our Facebook and our YouTube, so you can go back and listen to it again or share it with your friends and everything. So yeah, thank you.
Okay, thank you very much.